Okay, so we're going to start. People are on mute, but please send us a note if you want it to be unmuted, to ask a question or a comment. There's going to be a few other speakers during the course of the webinar. And so this is now being recorded and will be posted to PCOR and to several other health literacy listservs. Thank you for joining. My name is Michael Pasciuolo. I'm a professor of medicine at Boston University School of Medicine. And I've been quite interested in the intersection between health literacy and PCOR. I'm hoping the slides will advance. Let's see. Here we go. So to get started, PCOR in general has had a significant interest in funding projects in the space of health literacy. And that as a way of beginning, I'm going to show you some of the work that's happening across PCOR in health literacy in one nature or another. For example, here's a study about cancer screening for low-income or urban women that's funded by PCOR. Here's a trial to reduce obesity in primary care in Louisiana. And here's a chronic pain comparative effectiveness trial. And here is the Boston Bridge, which is a network in Boston to promote the potential for PCOR and clinical effectiveness to address disparities. These are different types of things that, in one fashion or another, these projects have chosen to focus on health literacy funded by PCOR. In addition to these, I'm going to show you three others, and we're going to have some slides later during the webinar about them. We have Laverne on the call, who's going to share some information and some slides about the Northern Neck patient advocates and providers for PCOR and comparative effectiveness research. We also have Leah Carliner. I'm not sure if I got it right, but hopefully when you get on you can Leah Carliner, sorry. Talking about clinical language concordance and interpreter use out of UCS. And then the Green Light Plus study, another work being done by Russell Rothman and the group out of Vanderbilt, which has been both a very important hub for PCOR research, but also for health literacy research. Laverne and Leah are on the call and are on the webinar and will share their slides themselves. And Russell couldn't be on the call, but he sent me some slides that he was hoping that I would share with him. All right, so the nature of this presentation really comes out of Eugene Washington PCOR Engagement Award that we've had. Actually, this is our 4th year in a row that we've had the Engagement Award to help support the Health Literacy Annual Research Conference in a grant called Promoting the Intersection of Research on Health Literacy and Patient-Centered Care. Here's the website. This is the most recent HARC meeting was done in October 2018 in Bethesda, Maryland. And I'm going to be sharing some of the findings and kind of salient points from that meeting. But really, all the presentations, I'll share that with you again later, but all the presentations are on the website, and we're going to talk also about the nature and methods for stakeholder engagement for the conference, which was actually a very important advance for us over the course of these last couple of years with PCOR in support of this conference. So effectively, when I talk about health literacy and PCOR, I want to convince you that really we should be thinking about them together. PCOR, patient-centered outcome research, really helps people and their caregivers communicate and make informed healthcare decisions, allowing their voices to be heard and assess the value of healthcare options. But this is very, very deeply intertwined with the phenomenon of literacy. Basic literacy, if you will, not health literacy here, but basic literacy is really a very functional concept. It's really a competence, a set of skills relating to a specific domain of human endeavors. We can legitimately talk about skills that a person needs, for example, to fix a car, or the skills that a person needs to, computer literacy, to interact with computers. Now, basic skills like reading and writing and arithmetic are very useful in many of these scenarios, but are not actually critical. I mean, there are people who fix cars who don't have those skills, and understand Chaucer. The demand is contextual. So the point I'm trying to make here is there is no one literacy. Literacy is always defined in the context of a set of competence that a person needs to do something. It also means, orthogonally, it also means there is no illiteracy. Effectively, the community, the health literacy community, does not use the language illiteracy. Not only does it have kind of a pejorative sense to it, it also kind of fails to understand the full nature in which that the demands have to be conceptualized as contextual. That said, the official definition for the United States of health literacy is the following. The degree to which individuals have the capacity to obtain, communicate, process, and understand basic health information and services needed to make appropriate health decisions. This is incorporated into Healthy People 2020. It's actually the same definition that was used in Healthy People 2010. And, basically I want to tell you that I really don't like this definition, and it's part of framing this whole topic in getting it wrong in a certain way, getting it wrong from a PCOR perspective, and I want to lay that out right here because part of what has to happen to bring these fields together is health literacy has to influence PCOR, and PCOR has to influence health literacy. So in what ways is this definition deficient? First thing is that it uses this term basic within the definition. And really what's basic to one person could be irrelevant to another person, right? If a patient has, say, cancer, and they are being presented with the scenario of if they should have chemotherapy or radiation or surgery or some combination, those decisions are critical, and what we do to support and uphold the dignity of that person in helping them to make those decisions in the widest ways possible for them in their life, they're critical for them, but they would be irrelevant for somebody else. We could not define any concept of basic health literacy across all people. What's basic, if you have asthma, how to use your inhaler and when to use which inhaler, those are basic for you, but would be irrelevant to a person who does not have asthma. So the concept of basic kind of ignores the critical nature of understanding the context in which this human being is situated. The next thing about this definition that's problematic is that it's not just information and services, but it's information, services, and skills. There are a lot of special skills needed in the context. It does not magically happen that you know how to use a glucometer. The provider, the doctor, the nurse gives a glucometer. It doesn't magically happen that everybody knows how to use that, or the inhaler, or the CPAP machine, and all the different skills that are needed in the context of health. Another important phenomena that has to be identified as deficient in this from a PCOR perspective is that the definition seems to endorse the notion of appropriateness. And I have to say this is effectively from a PCOR perspective an offensive aspect of the definition. What's appropriate cannot be what the doctor tells you. What's appropriate is what's appropriate for you. So the answer here is not to empower people to make appropriate health decisions. Appropriate from whose perspective? What the goal here is to empower people to make informed health decisions and actions. So this is really another way in which the building blocks of the health literacy field have to learn from and accommodate and adapt, develop a PCOR mindset, and it's happening. We're promoting this. Another thing here, and this is really also quite critical, is the definition is deficient in the following sense. It focuses on individuals' skills. Now, that's fine. Individual skills will be relevant. However, it's like blaming the victim in the context of clinicians who speak with incredibly dense jargon and health systems that are developed with incredible complexity and insurance systems that are developed in ways that are just beyond belief complicated. So all in all, what I want you to think about is the definition. Health literacy cannot only be at the individual level. This has to happen at the organizational level. It has to happen at the provider level. It has to across the system, across the care continuum. And if you hear people talking about health literacy and they're only talking about a patient's skill level, well, they don't have a broad enough perspective. And that's also part of what PCOR brings to the field of health literacy. And there's just many, many examples. So part of the problem is that things actually are very complicated in healthcare, and things have even gotten much, much, much more complex over time. You know, there's too much information. There's not enough time. We're asking people to do very heavy cognitive tasks when they're not at their best. And in fact, there's been an increasing role for the patients, much more self-care, many more forms, many more things that people have to do for themselves, direct-to-consumer advertising, direct-to-consumer genetic testing, and the whole movement towards informed shared decision-making and participatory decision-making really, in the end, is more taxing than it used to be. I am not advocating, and the health literacy field does not advocate to go back to a paternalistic model of care, but moving towards shared decision-making does require more work for patients at a certain level. And here is something where the health literacy field is massively needed in the PCOR space. This is like the counter vector from what I was talking about before. Effectively, health literacy says to shared decision-making, we will help you increase patient-centered care, but without overwhelming people. It's going to be about empowerment, not about knocking people down with a fire hose of data. When you in many contexts for what's happening now, all patients, really everybody has access to just a fire hose of information that could be coming at them about health, and it's overwhelming. It's just overwhelming. So we have to somehow figure out how to help people, drink from a fire hose. And it's an incredibly complicated thing, and it cannot happen without the lens of health. So these were the two keynote speakers from the meeting. Both of them in their own ways focused on parts of this puzzle that are incredibly complex and important and interesting. Marisol in particular, her background is really for ESL learners, adult English as second language learners. We're going to, Leah is going to be talking a little more about phenomenon of care with across language and language barriers in care that hopefully can be corrected. Marisol also really has served as doing research for people who will be teachers of English language learners and people with very basic literacy skills, and has been bringing health literacy work to that space in very interesting ways and very powering ways. Raymond, he comes from a very different background, and his work has mostly been to improve self-care skills for people with chronic health conditions. He also has a very deep background with multiple rounds of NIH funding for people with cognitive decline and health literacy in that context. All their talks, all their slides are on the website. We can show you about that later. An important part of thinking about this engagement grant that we've had from PCOR and conferences in general and engaging stakeholders is really how to do that in the context of a conference or really any activity. Is a very important component of what PCOR does and is advocated for. But then the questions are going to be like, how do you do it in a successful way? In the context of health literacy, part of the issue is who's going to be an effective stakeholder and how to facilitate that, how to design that for success. Really, without the perspectives of people with low health literacy, it's really going to be super easy to fail to understand how to respond to people's needs. At the same time, only engaging professional stakeholders, even though they bring added perspectives, how do you get to the actually perspective of people who are the least powerful in the system, who have the most vulnerability? And so I think we're going to share some information about how we endeavor to do that, and I think largely successfully. So part of the issue is really to design for success. So first thing that we did is each of the stakeholders that, PCOR-funded stakeholders that came to the conference, we had 19, we designed for each of them a path through the conference of their activities during the course of the conference in relation to their interests. This took, several phone calls with each of them to figure out, what their interests were and to design a path through the couple of days of the meeting for what that would look like. The next thing is we actually had a pre-meeting for the stakeholders that was focused on them, really just to develop and make sure that there was a common vocabulary about the context and the nature of research and a research meeting and how to get the most out of the meeting. And we really did charge them with, it's not advancing, hold on. Advance, please. I got a stall on the slides. We'll see how this goes. There we go. We really did, we gave them abstracts in advance. We helped when needed, when people needed it or wanted it, we helped them prepare questions that they would be asking in sessions. Moderators were oriented that the stakeholders got to ask the first questions during each of the question and interaction time, that they were introduced to the moderators at the beginning of each of the session before the speaker started, and that it was kind of designed for success in this way. And we charged each of them with approaching investigators at the meeting to challenge them, to go up to people at their posters and to say, tell me about this work, and then to say, tell me how this advances the voice of patients, or whatever nature of that question they wanted. Or are you satisfied that you are getting to know what people need in your, whatever way they wanted to do this, we helped them kind of, if they needed help or wanted support, to come up with a set of questions that they could challenge almost anybody at their poster to push the envelope about stakeholder engagement in the research of all the people presenting at the conference. This was incredibly engaging for them. It gave them a very active role in presentations and in poster sessions, and it gave them a very active role. And it also, they really enjoyed this. They had basically they could see it was a lot of value added to the investigators, that they would be challenged in this way to talk about this. And frankly, a lot of investigators had not come prepared to have someone ask them these questions at their post. So that added that was quite interesting and engaging. It's not advancing. Let's see if I can get it to go again. Okay. With that, I'm going to take a pause and give over the mic to Laverne to describe their project. Dr. Carter.
Thank you, Dr. Michael. I'm sure I'm saying good morning to some who are on the West Coast, and And in the Midwest, I want to say good afternoon, good morning, based on where you are. I think we're so excited to be part of this webinar, and we're excited to be part of PCOR. Our project is Northern Neck Patients and Providers for PCOR. Just a little bit of context about where we're located. We're very rural, we're very remote, but we're within 3-hour driving distance to D.C. and Richmond. But we're on a peninsula, beautiful peninsula, 48,000 residents, 33% African American, 65% white, and an emerging Latino population that's undocumented. Very low functional literacy levels, low reading levels, low numerical levels, and very low income levels, and we are a health services desert. So that's the context of what we're looking at in our area. Next slide. The goals of our project, we have a 2-year engagement award. We're in year 2. Our efforts were to build a collaborative of patients, providers, and faith leaders, and pretty much like Michael said, following the PCOR model where the patients are the center. And these are a couple of pictures from our meetings to increase the capacity and competence, both, and this is public health language, of the collaborative to address the health literacy deficits and the multiple chronic conditions that face African American community, and to create a tax-exempt nonprofit to sustain the PCOR investment through external partnerships. Next slide. What are our project activities? Over the course of 2 years, to conduct 8 collaborative meetings to build the network across 4 counties, organizations, churches, and residents. And we've worked all over the United States, so we understand that most systems, even urban, rural, they tend to be siloed. Everybody does their own thing without association with other people, and that's even more so in our rural area. To conduct 6 focused and rigorous training sessions led by medical and public health experts. I have pictures here of Dr. Robert Palmer, who's one of the top geriatricians in the country out of Eastern Virginia Medical School. I have his picture because he is a rock star in our region. When he comes and does training and speak, we have overflow crowds, and people hold on to every word he says because he takes very complex principles and concepts and breaks them down to the lowest common denominator. So he is so highly rated amongst our patients and our groups. And also Dr. Kanisha Moore-Bryant, who's had quite a bit of PCOR funding, it would be the second rock star. She's a nurse, trained as a nurse researcher with mental health. I want to talk about some strategies that we had to do because the first, and I'm going to build on what Michael said, we have tremendous levels of functional illiteracy in our area, and that has been almost devastating to see that in action. Our patients are our center. One of the things that our organization has done for 30 years is work in very poor communities of color and translate public health and healthcare maintenance principles down to the lowest common level. And I put parentheses around lowest because we also work to bring people up and to have teachable moments and train people. And it's really exciting work. We translate complex public health and medical concepts using 3 syllables or less. And that I just tend to, I've been doing this nearly 40 years, and that's something that I think about. If it's more than 2 or 3 syllables, folks are going to get lost in it. I'm trained in public health, and I've done that work in communities for probably about 20 years, and we're doing that here. And Dr. Palmer and Dr. Moore-Bryant also do that very well. We use culturally appropriate videos. We use gaming activities where we do team feuds to make sure they're learning and getting those concepts, and they love that. And we use group feedback and discussions. Michael had a slide that talked about what stakeholders to engage. We have our health systems at the table. We have our area agency on aging at the table. We have several practitioners at the table, but everybody understands that those 18 patients at the table are the most significant people there. Most of them have multiple chronic conditions. They've been engaged. Next slide, please. What is our impact? We're at 16 months. We have a very engaged and diverse collaborative, 2 hospital systems, 2 area agencies on aging, a local health department, 4 churches. In a rural area, your most significant institution is a church. So we have 4 lead churches that are highly engaged. We use social media, and I have our Facebook page here for if you want to go and see. This area, people, if you want something out, Facebook is the way to go. We have Facebook. We use a mobile app that people have downloaded and get information. We've completed 4 structured training workshops where we've seen significant changes in knowledge from pre-post tests on all measurements and very high satisfaction ratings. And the same with our collaborative meetings. We have started doing our engagement, diving deeper and engaging 240 patients. We did 54 patients actually this past weekend, and it was riveting. I had people standing in line thanking us for the knowledge, the education, and what we're about to do. And we heard some just phenomenal stories. Michael, I like what you said about having people question researchers. We talked about the vertical power relationships between patients and doctors. Folks were really moved about that because they talked about being afraid of their providers and the healthcare system. And we've established a tax-exempt nonprofit to sustain our efforts, and we actually have been adopted by University of Arkansas Medical Sciences and Eastern Virginia Medical School to move forward to engage in more intervention work around health literacy. Our number one issue here is health literacy. So we've had to really engage in some innovative strategies, and we do ask people, did you understand what we said? Are you getting it? And they are getting it. And this past Saturday, we had meetings with 60 patients across 2 churches, and it was absolutely amazing. And I think that's all I had. I'll stop there.
Great. Thank you so much, Dr. Carter, for telling us about engagement efforts. So we're now going to shift gears, and Dr. Carliner, you help me with that, please. I'm sorry. I'm going to turn over to you.
Carliner, you got it.
Oh,
hey,
my
goodness. Can you hear me?
I got it wrong, but yes, I can hear you.
No, you got it right. It's fine. Okay. Can I have the next slide? There you go. So, yes, I'm really pleased to be involved in this also, and I've been enjoying listening and learning myself. I think initially I said to Michael, I do language work, not necessarily health literacy work, but I really resonated with me the idea of context and the need for informed health decisions and actions. And language is so fundamental to that for patients with limited English proficiency. If they can't express themselves in a medical encounter, if they can't be understood in a medical encounter, then that's their context, and then there's really no option for informed health decisions and actions. So my project, also funded by PCOR, is the Language Access Systems Improvement or LACI study. As I've mentioned here, language access is fundamental to communication. There are really 2 approaches in the clinical setting that are used. One is language concordance, which that has its own challenges of ensuring that clinicians are fully bilingual and able to communicate appropriately with patients. and the other is utilizing professional interpreters, but access to services can be challenging. And so what we've done is we've evaluated an improvement process that's been put into place by the health system at University of California, San Francisco, where I am. That was two-pronged. One was increasing access to professional interpreters through video conferencing, medical interpretation, and the other putting into place a bilingual clinician certification program. Next slide, please.
Okay.
Can I have the next slide, please? Can you hear me?
Yes, it's just a little
Hello?
slow.
Oh, okay. Just wanted to make sure I wasn't talking into a void.
Oh, you're doing great. I'm sorry about that.
Okay. No problem. Our study objective was really to evaluate the impact of LASI on both communication and clinical outcomes for patients with LEP. And I'll talk about our stakeholders on the next slide, but we have collected a lot of different sources of data. The first and largest is over 1,400 interviews with patients who are Chinese, Spanish, and English speaking. And these were telephone interviews 1 week after primary care visit, and we're comparing the pre-LASI time period to the post-LASI time period. We've also audio recorded 190 primary care visits with the same population of people. And then we're doing a larger electronic medical records evaluation that's 4 years of data, but where we're not actually speaking to patients. For implementation and dissemination, and really I view this as another level of engagement, we've conducted 4 focus groups with patients in Chinese and Spanish, and then 16 physician stakeholders with semi-structured interviews. Next slide. Thank you. In terms of our stakeholder engagement, we have a group that named itself at the beginning, which was about 3.5 years ago, the Advisory Collaboration on Language Access, or ACLA. It's co-chaired by a patient stakeholder and a clinician stakeholder. And when Michael was talking about some of the challenges, how do you actually engage stakeholders and the patients in the process, one of the things we struggled with early on was could we really have bilingual patients as our stakeholder? And what we opted to do was, or to have monolingual patients as our stakeholders, but because we were working across multiple languages, we opted to engage bilingual stakeholders, but who had experience with monolingual family members or being monolingual at some point in the past themselves, and that have experience in the health system in which we're working. We also have advocacy and policy stakeholders that are very engaged in policy in California. We felt like it was important to bring the system because it's a systems intervention, and we wanted to feed back data to the system to bring the system stakeholders from interpretation services. And also we have a very diverse research team. And our research staff, in fact, have many experiences with their own family members and their own immigration stories to contribute as stakeholders.
You can still look at
and
me and say, hey, Daddy.
Engaged our stakeholders from the very beginning of the development of our outcomes all the way through now to where we've been doing some more thinking about dissemination and implementation, including our primary co-chair stakeholder, patient stakeholder has done recruitment for us because she wanted to. She wanted to engage at that level with us in recruiting patients, and also has helped us really on every level, every step of the way. We do have an annual half-day meeting in person, and we do a lot of co-learning there where the research team is really learning from the variety of stakeholders in the room. Next slide. So I was asked to just show some of our preliminary results. We're still in a preliminary results moment, but I was reflecting on what Michael was saying about not just focusing on the patient skills. And in fact, a lot of what we spent quite a while doing with our data was matching patient and physician language skills, because this is really about the system meeting the patients where they are across, and we can't just focus on what the patients are bringing to the visits, but also what are the physicians bringing in terms of language skills. and we had a number of data sources for the physician language skills, but we were able then to categorize all of the visits of the data we collected into whether they were English concordant visits, non-English concordant visits in Chinese or Spanish, and also partially concordant visits, as well as discordant visits that should have professional interpretation. And we were really looking to see where we were able to increase the use of professional interpretation from pre to post, which we did have success in doing, however, not as much as we would have anticipated, which is where those patient focus groups and the physician stakeholders come into place, where we're really trying to understand what's happening when the professional interpreter is not in the room. Why is that happening from both perspectives? And then lastly, in terms of some of our early data from our audio recordings, we've been able to evaluate them using a system called the RIAS. And we're finding that discordant primary care visits using professional interpretation ran longer, addressed fewer problems, and in fact have less psychosocial and socio-emotional content compared to the English-speaking visits. So these are, right there in the communication in the room, what's really going on between patients and doctors when there is an interpreter that's having to be a conduit for them. Next slide.
Yeah, no.
I'm going to take just a half a moment to try to fix the muting issue because someone keeps talking. So just a moment, sorry. Leah, can you continue?
Yes. So I think I just have one more slide. If you could go to the next slide. And I just wanted to say that we have a number of other analyses that have really come out of the data that our stakeholder, our ACLA group, has contributed to, what else can we do with this incredibly rich data that people have taken the time to participate in this study to allow their primary care visits to be audio recorded. And so we're looking at, interpreter quality by modality, and we're really looking at what the patients say about different kinds of interpretation over video, telephone, and in person. We're looking at how can we use patient ratings of physicians' non-English language ability? What would that look like? How many patients would we need to talk to do that? We are looking at depression recognition and treatment within the primary care visit. We're looking at the usefulness of the after-visit summary by language and ethnicity and by some more classical measures of health literacy. And we're also looking at what happens outside the visit with the physician, because patients have said to us, it's not just about that. We have to come in and talk to people at the front desk. We have to interact with the MAs. Are they using interpreters? How are they communicating directly with patients? So we're really looking at a lot of outcomes that we hadn't originally planned, but that are being influenced by our stakeholder group and by the richness of the data, because people have been so generous to participate in our study. Thank you.
Yes, thank you so much. Thank you so much, Leah. I've been a big fan. I actually, my MPH mentor was Deb Roeder, and did my own stint as RIAS coding and all that. So I'd love to hear more as this evolves. So the next couple of slides I'm going to share from the Vanderbilt group. Vanderbilt really has been one of the very successful PCOR sites for multiple activities and also for health literacy activities. PCOR has funded PCOR-Net, which is a national network to support pragmatic clinical trials and comparative effectiveness research. And effectively, I'm not going to tell you all about PCOR-Net, but one of the components of PCOR-Net is the STAR Clinical Research Network, led by the Vanderbilt Group. STAR is Stakeholders, Technology, and Research Clinical Research Network. Their network data infrastructure covers 14 million patients across this map, across these organizations. They have had a series of different projects relating to health literacy and numeracy. Here's an example. Sunil and Russell published earlier this year about health literacy, willingness to participate in different types of research. This was kind of a preliminary activity that they had that they were going to do. That people with limited literacy and limited health numeracy were also less interested in participating in research. And this just gets to a broader issue of health equity and also just, you know, how will we do good research and how will we succeed, or what will need to be done to engage and to make sure that we do have a good distribution, appropriate distribution of participants in our studies, and highlights that actually health literacy is one of the barriers that has to be contended with, which is really not such a shock. If you look at the experience of enrollment into studies, and the consent process is super scary, even if you actually understand the legalese. So it's just not a big surprise. It just hasn't been very high on people's radars per se about the whole process of doing research and engaging people in research, that you have to also take on the health literacy agenda. Another thing that's very much in play right now is their Greenlight Plus study. Greenlight is a study that promotes obesity prevention work for young children, and the Greenlight Plus project is an ongoing adaptation of Greenlight that's being done at Vanderbilt, Duke, UNC, NYU, Stanford, and Miami to adapt and extend Greenlight using text messaging and web-based goal support for parents of young children, and also for training of pediatric residents and for communication training. And the whole project of Greenlight and Greenlight Plus, the Greenlight Toolkit, comes through a health literacy lens. There's a few other things I can point out for people to check out. I helped develop through UNC, some other fantastic partners through Northwestern and elsewhere, a health literacy data map. You can go to this website and get the data down to the local level, at the city and county level, for health literacy. Here's another thing to just shift towards, which is the stakeholders that came to the meeting this last year really had a very good experience. Here's some representative quotes. Let me start by saying that I enjoyed the conference. I felt my voice as a patient was welcomed by other attendees and presenters. I never felt as if my perspective was discounted or that what I had to say was at all diminished. Or another person told us, in every session it seemed I had something to say, and in every session I felt the positive reaction, nods, reflective expressions, and a thank you, appreciate your being here. And so with that, I actually want to show you something that we did, which was extremely engaging, extremely fun, and it was part of what we did at this conference, we called it Mission in a Minute. We had all the stakeholders do it, but we also had other people at the meeting do it. So what this was we invited people into a room with a green screen. We prepared them by asking them to think about what their mission is in PCOR, what their mission is in health literacy, if there's a nexus there for them, and if they would want to talk about this. And we edited down their videos to be 1 to 2 minutes long. As it turns out, the audio is not working through the webinar app right now. So what I just want to point out that this is on our website as an example of something. It was very empowering for people to do this. It was really fun, and also we got to share these clips with people. So if you're interested in the model of something to be done with people, or even just to listen to some of what they had to say, come to this website. You can see that we really were able to engage with a fair array of people for at the meeting, and also specifically even to come into a room and to express themselves, and then to splice it down. And we sent all these clips back to each person that they would endorse, that we could share them, and that they would endorse that what we created really did reflect their message and their perspective and their values. And this was really a fun and engaging, and I think quite a meaningful activity at the meeting. And people, we had prepared the stakeholders in advance a little bit to do this, but even still, some people took this on like they had to have a script. Other people took it on much more in a narrative fashion. That's all. It was all good. It was all fine, because we could edit it down to a shorter piece. We told them that we would do that, and they would endorse that. While I'm on the website, I can also show you that you can go and see basically the whole agenda and click through to their presentations. There's the speakers for not only just the keynotes, but all of the panelists, and also to a lot of the other information. Not only that, you can also go and see all of the presentations at previous HARC conferences. I think that's right around here, past conferences. So this year was, in fact, the 10th year of the Health Literacy Annual Research Conference, and it was a fantastic go at it. With that, I guess I could also show you another thing that's, I think, can be very useful in this space, which is the Health Literacy Tool Shed. So the Tool Shed is another kind of building block in this whole field, which is these are measures tools to measure health literacy at the individual level. This is part of the puzzle, not the whole puzzle, but part of the puzzle. And we have come to curate measures in this space in different languages and in different contexts, validated in different populations in different parts of the world even. And in fact, at this point, we have 183 measures on the site to measure different types of domains of health literacy, different specific kind of clinical contexts, different methodologic issues are also represented here. But I want to just point out, because we have Leah on the phone, I want to just point out we have been working very hard for language. And so you can see the range of languages included, from alphabetically here, from Arabic down to Vietnamese, that we've been working very hard at this. So the field has been growing in very interesting ways, including reaching into new pockets of linguistic issues and new pockets of new populations, new clinical topics. And with that, I'm going to go back to the slides. All right, thank you. And shift over to, I just showed you the tool shed. Shift over to the following, which is the next HARC meeting is actually being done in collaboration with the International Association with the International Conference for Communication in Healthcare. This conference itself is already a collaboration between the Academy of Communication in Healthcare, which used to be called the AACH, the American Academy, is now called the Academy of Communication in Healthcare, and what used to be called the European Academy of Communication in Healthcare is now the each International Association for Communication in Healthcare. These are all coming together in October in San Diego for the next major health communication conference. We'll again have a significant health literacy focus, and we'll again have important PCOR influence. it will have a significant PCOR influence, not only because I'm deeply involved, but also many other kind of very dedicated PCOR-oriented folks, like Russell Rothman from Vanderbilt, who is currently the president of the Academy of Communication and Healthcare, and several of our junior mentees who are leading the program for the abstracts and everything for the meeting. With that, I'm going to unmute the line if people have questions. I hope we can do this in a manner that works. We're going to unmute all if anyone has any questions, although you can also email and we can follow up in that way. You can also type to us if you like.
Hi, Michael. It's Laura Koloskowski calling in from Ohio. My question, well, first my comment is thank you, because over the past 3 years or so when I've been involved with HARC and attending as a PCOR ambassador, it's been an amazing experience, and I've learned so much that I've been able to carry back to our own research work within our PCORnet, Patient-Powered Research Network for Multiple Sclerosis. So I'm just wondering, what are your next steps? I realize your funding to work with the ambassadors has expired or has been exhausted now, and there's not that invite to attend this year's conference. But I'm just wondering if there are plans to do anything else with the ambassador group who's really been schooled in this now.
Well, thank you very much, and you have really been one of our steady ambassadors over the years. It's fantastic. Thank you for coming. It's true the funding is exhausted, but we're not exhausted. But we don't have a vision yet. We don't have a plan yet for funding of next activities. We basically joined forces with the ICCH meeting, as I mentioned, for 2019. For 2020, the vision is coming together that the meeting would be back in the Baltimore area again. We have in the past tried to keep it in Bethesda or DC because many project officers from NIH would attend. Would not be able to attend when we go out to San Diego, but some collaborations. It seems likely that it may be back, maybe in Baltimore in 2020, and we don't have a plan yet for funding for ambassadors, but we're certainly not against ideas.
And I'm not specifically even talking in person because I realize the logistics and expense of that is exorbitant, but I would certainly love to have some sort of conversation with you all about ways to continue the enthusiasm for health literacy and the learning that's taking place. So, and it doesn't have to be in-person meetings necessarily.
Yeah, no, you're right. We will continue to push out content. So, the meeting again will be on our website, and we will be able to connect everybody to it. But it is not as easy, when you're not in person. It's not as easy to kind of get things as creatively mixing together as when you can actually walk up to someone at their poster and say, "Tell me how your work advances the cause." It's just a different kind of experience. But we can be in touch.
I guess I'm saying we'll take what we can get in the way of exposure.
I see.
Yeah, exactly. So I didn't communicate that real well. We want to continue to be involved with you is my message.
Great. We have several of the Mission in a Minute videos do relate to your research network. That was a tease to try to get you to watch all of them.
Mm-hmm.
Okay, so we're getting towards the end of the hour, and if people, please send us any feedback or comments or questions. I think it's just there's still loads of opportunity for improving the intersection between health literacy and PCORI, between methods and approaches for engagement and for research and measurement across all these dimensions, such that both health literacy can advance in how we pursue patient-centered care and patient-centered research, and also how the voice of patient-centered research can improve methods in health literacy research and practice. With that, I'm going to thank everybody for participating and for supporting this, and we're gonna finish up. Send us any thoughts. All the best.